So thank you for coming to this FASD 101 session with Dr. Gail Andrew. Education and training is a critical aspect in the government of Alberta's FASD 10-year strategic plan. And that is addressed through various initiatives such as this FASD Learning Series. So we are pleased with the ongoing interest and attendance in this initiative. Before I introduce Gail, I just want to remind you guys that evaluations are going to be emailed out to you, and I think everyone signed that sign-in sheet at the back, so that will let us send the evaluations out to you. And so now I will introduce Dr. Andrew. She has received medical and pediatric training at McGill University, and as a developmental pediatrician, good tongue twister there, has worked in childhood disability. Currently the medical director of the Glen Rose Rehabilitation Hospital, FASD Clinical Services in Edmonton. That includes diagnosis, training, education, and research on FASD. She has consulted to the Alberta Cross Ministry Committee on FASD and is on the board of directors of the Canada Northwest FASD Research Network. Dr. Andrew was the scientific chair of the Alberta Consensus Conference on FASD across the lifespan, which was earlier in October this year, and that produced a nice consensus document that will guide the work in this FASD field. So now please welcome Dr. Andrew.
Well, thanks very much for coming. As you heard, FASD has been not just an interest professionally, it's become, I think, a passion for me. And although I've had great opportunities to attend lots of workshops, seminars, research presentations on FASD, at the end of the day, I think I've learned most of what I know from the children, youth, and adults who are affected by FASD, and most importantly, their caregivers, because they really give you the life story of this disability. And I'm often asked, well, what makes FASD so special? Because I work with children with autism, cerebral palsy, chromosomal anomalies. To me, FASD is so important because it is theoretically a totally preventable condition that ends up with a lifelong disability. So I think we have lots of opportunities. So we have an ambitious time ahead of us. The goals for the session, I'm going to talk a little bit about the history and the terms that we use in FASD. I'll talk a bit about the science, the biology of how alcohol acts on developing brain cells. I'll walk you through the process of how we make the diagnosis in a multidisciplinary team to identify, do we have evidence of organic brain damage for the diagnosis? And most importantly, we'll talk about how can this present across the lifespan and what supports are needed across the lifespan. So first off, the history of FASD. It's nothing new. In fact, in the book of Job in the Bible, it is mentioned about the harmfulness of using alcohol during pregnancy. There's some examples in early artwork from the Middle Ages and into the 18th century in specific paintings of women in debauchery, in kind of medieval situations, and the children in the paintings have the face of FAS. So why did it take us so long as clinicians to recognize this disability? It wasn't until 1968 that the first medical reports came out, and that was in France, Dr. Lemoine and his group. In 1973 in Seattle, Washington, Dr. David Smith and his colleagues recognized a pattern of malformation in children with severe developmental disability, and their common factor was all the birth mothers were alcoholics. But I must admit, in 1973, although I was supposed to be reading medical journals, it was not on the medical journals that ever crossed my desk. It was an obscure genetics literature. So it's not really since the 1990s that we really have come to understand what this disability is. But even though we've had increasing knowledge at a very fast rate, a lot of the information is not included in our professional training programs. I know when I'm teaching medical students and residents about all you need to know about developmental disabilities, we get a very small, 1% of their whole curriculum that we can describe all a developmental disability. And we can hardly even get the word FASD mentioned. Teachers, the same thing. In the average teacher's training, they do not get a lot of information about FASD and what strategies you need to put in place. So that's a real area that we need to ensure that every bit of professional who is going to be impacting on the life of a child, youth, or adult with FASD has a good background knowledge. The animal research has told us a lot, and I will spend some time talking to you about the biological mechanisms of how alcohol causes brain damage. A lot of the clinical research where we are beginning to understand about how the brain works in FASD and how to approach a diagnosis has come from the University of Washington in Seattle. Dr. Ann Stryskuth, Dr. Sterling Claret, and his group have really contributed to the fundamentals of what this disability is. In the United States, the Institute of Medicine called a group of experts together in 1996 to really bring all of the information, what we know about FASD, together at that point in time. The United States, again, in 2004, did another clinical practice guidelines. In Canada, people working in the field were brought together in 2005, and we published the Canadian guidelines for FASD diagnosis. So you can see, this is just 4 years ago that we had the first Canadian consensus on diagnoses. And we know a lot more now in 2009 than we did in 2005, so that, we have to alter that document as well. Toronto Sick Children's Hospital has an organization called Mother Risk that has been around for about 20 years and working broadly with a group of how to have a healthy pregnancy as another example of some work on FASD. We're very privileged in the Canada Northwest to have a collaborative effort of all of the governments of BC, Alberta, Saskatchewan, Manitoba, Nunavut, Northwest Territories, and the Yukon. All of our governments have said, yes, FASD is a priority for our peoples, and we need to make a difference. So they created the Canada Northwest FC Research Network, where there's representatives from each of the provinces who are to drive the knowledge in this field. And our network is working on prevention, diagnosis, and most importantly, intervention and supports. There's also international work in this field that covers countries in the Ukraine, Italy, South Africa, Australia. It's beginning to be recognized all over the world as a problem. And this is actually, there's been a lot of denial that FASD is a problem in many countries. So it's been a huge movement that we have an international group now working with us. So talk a little bit about the challenges of FASD, why maybe there has been some slow movement. There's a lot of confusion in the terms. There really has not been a consistent approach to diagnoses. That's led to overdiagnoses, and one of my concerns has always been the very eager labeling of an Aboriginal child in foster care who has behavioral difficulties as FASD without carefully thinking about what other things could be contributing to that child's difficulties. On the other hand, there's the underdiagnoses. How many children in the ADHD clinic from a higher socioeconomic group may have FASD, but who would ever ask the question, did their birth mother drink during the pregnancy? So we need to make sure that there is a standard and a rigorous approach to diagnosis, and we'll review that later. where do you go to have access to a diagnosis? We don't have sufficient professionals trained around how the brain dysfunction of FASD. We also don't have teams brought together to diagnose FASD in sufficient capacity. And there's always a wait time to get in to have a multidisciplinary team diagnoses. And one of the main things that came up at our consensus conference is we need to increase capacity, but we need to do it with accuracy and sustainability. Another big challenge is after diagnoses. What next? What are the appropriate management and support systems that need to be put in place that are based on good evidence? We have a lot of good pilot projects that I've seen some really good work. Can they be replicated? Can every child who has that need have access to that same level of service? And we know this is a lifelong disability. Do we have the sustainable funding so that children, as they transition into adolescence and ultimately into adulthood, that the support follows them across that lifespan and sets them up for success to reach their full potential? In the past, there's been a lot of unrealistic goals set with a focus on simply preventing mothers from drinking, because it's a very simple equation. If you don't drink during pregnancy, this will not be that child's disability. But there is so much profound issues of why women drink that are not addressed simply by saying don't drink. So we need to shift into the why women drink in order to make an impact on prevention. The other unrealistic goal is to change the individual with FASD. Tell them how they need to change in order to just work harder, just do a better job. This is a model of brain damage. If a child had been in a car accident and had brain damage, you wouldn't insist that they just barrel on through. You would make allowances. You'd adapt the environment to meet the needs of that child. Well, in our kids, we just didn't see the accident happen, but there was an accident that ended up with brain damage. So we need to apply the same principles. How can we, as the caregivers, people who can set up the environment, how can we do a better job to help that child, youth, or adult with FASD do their best they can? With all these challenges, that was one of the many purposes of the consensus conference on FASD across the lifespan that was put on by the Institute of Health Economics and the Alberta government just recently. And you can download the consensus statement from that website, the www.ihg.ca. And the conference brought together experts in the field, and the information was presented to a jury from mixed backgrounds. And out of it came recommendations that will address diagnosis, prevention, intervention strategies, and help set what we're going to do in Alberta over the next 10 years. So please go into it. It is now, we've turned it into an action plan, and hopefully we will be able to fill in all those areas of gaps where we don't have all the research answers as yet. And then more importantly, translate those research answers into practice that's accessible in whatever community you're living. Just going to clarify some of the terminology. The initial terms that were reported in the early literature were FAS, partial FAS, and FAE, fetal alcohol effect. FAS refers to the full syndrome where you have growth deficiency, the classical dysmorphic facial features, and significant dysfunction. Partial FAS, you don't have all of the physical features, but it's still a visible disability. In FAE, fetal alcohol effect, that term refers to someone who does not have any facial features, growth deficiency, but has difficulties in functioning, the invisible disability. Unfortunately, with the term effect, it almost implies that it's just a little bit. It isn't as serious, but through some of the longitudinal follow-up work, it's actually been shown that people with who used to be called FAE do more poorly than those with FAS. Because they weren't identified early, they didn't get the supports, and they were always set up to fail because they looked like they should be so capable. Two of the other terms that the Institute of Medicine brought forward to try to clarify this dilemma was to call children with the invisible disability, the FAE, to use the term alcohol-related neurodevelopmental disorder, which is a big long term. It does describe that alcohol was associated with that particular neurodevelopmental disability. But it doesn't really capture the full disability. ARBD, alcohol-related birth defect, was another term that was brought forward. And that's to remind us, especially as healthcare providers, alcohol not only damages developing brain cells, it can have an effect on the development of the heart, the kidneys, eyes, the auditory system. And sometimes we forget that when we're working with our children. The term that we now use as an umbrella term, it's not a diagnostic term, but it's an umbrella term that captures all of the full spectrum of disability from prenatal exposure to alcohol, FASD, fetal alcohol spectrum disorder. And this really does explain what this disability is. The F standing for fetal, so that the changes happened during that development period in utero and fetal life. Alcohol was the teratogen, which is the agent that causes cell change and damage. S stands for the spectrum. It really is a spectrum of damage that presents from mild to severe, and that's why a lot of the children, as we assess them, they have a unique profile with some emerging similarities, but unique to them. Disorder is really a good term because it explains that it's not a delay in development that we see. It's a disordered pattern that at the end of the day ends up with that individual having difficulty in being able to function and adapt as expected across their lifespan. And the spectrum, this is just a visual to kind of get the sense of how broad the spectrum can be. It can be simply the loss of genetic potential, what that child could have done had they not been exposed to alcohol. It may present as a variety of behavioral difficulties, learning disabilities, being a slow learner, having significant mental impairment, or result in pre or perinatal death if the damage is profound. So this is quite a continuum of what can happen through prenatal exposure to alcohol. It's very easy to, at the one end of the spectrum, around slow learner and mental impairment, is yes, this could be caused by organic brain damage. At the other end of the spectrum, it's easy to see, oh, that's just the environmental impact. But with FASD, we have actually a mixture of both, but even that loss of genetic potential that we can't measure is a result of the organic brain changes from the prenatal exposure to alcohol. How big a problem is this, the prevalence? We don't have really clear numbers. It's quoted that full FAS, the full syndrome, is 0.5 to 3 per thousand in the general population. The old term FAE, 3 to 5 times higher. Recent data from the United States says that FASD is 9 per thousand. So again, not uncommon. We know that it's higher in high-risk populations for those reasons of the why women drink. There's some emerging factors on genetics that influences alcohol metabolism in the mother that may have increased the risk. One of the problems in prevalence studies is we are not using consistent diagnostic criteria, so how can we count how many kids with FASD we really do have if they're not all coming forward for an accurate diagnosis? So we really need to have better access for diagnoses. The cost to society, $1.2 million per individual across their lifespan, in addition to the regular costs. And we can't put a dollar on the human cost. Not only the cost for the individual affected, but I get to listen to the stories of caregivers and the cost that they put in I think the stress, the caring hours is huge. One of the other aspects of FASD that makes it unique is the multi-generational impact. I see many of my young children coming to clinic are being raised by their grandparents. And the missed generation, the birth mother or birth father, they're missing in action. They were also exposed to alcohol. So we have mothers who have FASD themselves becoming pregnant and giving birth to children with FASD. Grandmas are trying to take care of the children, and they may not have all the skills or the physical energy at that point in their life to provide this. Some of the examples of high-risk prevalence, Dr. Christine Locke and Diane Fast in British Columbia went into, it was a unit in the juvenile justice system, and they did assessments on the youth who were being admitted. And they had, in this particular group, they studied 287 sequential youths were studied. Average age was 16 years. With 67 of the children received an alcohol-related diagnosis, so almost a quarter of the children entering into a youth justice system facility. 1% had the full FAS, 22% had the invisible disability, and were never diagnosed until they entered this particular program at age 16 years. We're getting some more information for children in the foster care system. This is done in Manitoba, and they found that children with FASD are more likely to enter earlier into foster care, to stay longer in care, and in just one of their small samples, 17% of children entering into the foster care system received an alcohol-related diagnosis, and this research is still ongoing. Dr. Susan Astley in Seattle, Washington, has produced is quite a nice software program that will analyze a digital photograph of the face to look for the facial features of FAS. And she just used there's no identification of the children when she does her study. So it's just a T picture, the eyes and the midface, nose and lips and philtrum. And the face of FAS was found in 1 in 100 children in her foster care sample. So I think those are striking numbers in high-risk populations of how many we have. But we need to really know through better diagnosis how many actually we have in our population. I'm going to talk a little bit about how complex this diagnosis is. It's not simply just doing that eyes, lip photograph. It's complex because, first of all, we need the confirmation of alcohol exposure in that pregnancy. You can't always assume because mom drank in this pregnancy that she drank in that pregnancy. And we actually found that out in our clinic. We had two siblings who were in foster care. And we assessed them through our clinic because there was on a written piece of paper that there was alcohol exposure. And we felt it was from quite a reliable source. When we did the debriefing, the birth mom attended the debriefing to find out the information. And our clinicians were puzzled because we had two very different profiles. One of the little boys had a common type of learning disability. All of his other executive functions were perfectly intact. So my social worker and I met with mom to see if she was okay with attending clinic. And we just said, well, can you tell us a little bit more about kind of your story? And she said, well, I didn't drink with, I'll call him Johnny, but I did drink with Joey because of circumstances in my life. And what mom said matched up with our test scores perfectly. But there was the assumption that she had consumed in all pregnancies. Alcohol exposure itself is only a risk factor. It doesn't mean a diagnosis, a definite diagnosis. And we'll talk about some of the other compounding factors. You need to have access to a multidisciplinary team to do the assessment of what is the spectrum of disability. And then you need to, I always say we do a disservice if we only diagnose. Diagnosis has to be a positive, meaningful experience and lead to something, an intervention that's across all areas, educational, social, medical, mental health, that's specific to that individual's needs. The other complex part about the assessment is you have to look at all the other contributing pre- and postnatal factors. It's a diagnosis of exclusion. In medical term, we use differential diagnosis. You're always asking yourself, what else could it be? There are comorbidities. What else is also present? And many of our children leave clinic with 3 or 4 diagnoses, not just one. And then you have another layer on top is the compounding situation or very supportive situation by the caregiving, where the child is living in their environment. One of the things that when we see very young children is to not forget that we often have increasing gaps over time, and the importance of providing longitudinal follow-up, of ensuring that that child has the monitoring and supports, especially across transitions. And also looking at secondary disabilities, which we'll talk briefly about as well. So every time we are approaching diagnosis of FASD, this is what we need to be considering. I'm going to talk a little bit now about the basic science of alcohol. And this will also, I think, help you understand the complexity. It's not simply a linear thing. Alcohol in, increasing amount of alcohol, increasing amount of disability. It doesn't work like that, especially in the human population. Alcohol, we know, does cause significant cell damage from the learnings through animal research. In humans, we know that the impact of alcohol depends on the amount of alcohol consumed, the pattern of drinking. Binge drinking has far more devastating effect than the same amount of alcohol spread out over a week. The bottom line is no alcohol is recommended in pregnancy or even in contemplating becoming pregnant. But the binge drinking pattern is far worse because suddenly the mother has a high blood alcohol level, and the mother, through the placenta and her circulation to the baby, it's a direct pipe. What she drinks, baby drinks. That binge, that high level, goes to the brain cells. The damage also depends on when she drinks it. There's different critical times in the whole of the 9 months of pregnancy where different organ systems are developing. For example, that face that we're always looking for a full FAS diagnosis only happens if mother drinks day 19, 20, 21 of pregnancy, 3 days in 9 months to get the face. So are we surprised that most of our people with FASD have no visible disability if we're looking for the face? And we know that other parts of the body, heart develops at a certain time, kidneys and so on. But you know what the brain is doing? The brain develops from almost the point of conception to the point of delivery, and even in the first year of life, there's continued rapid growth of the brain. So the huge impact of having a stable, nurturing postnatal environment to help support the brain development is huge. So the brain, there's different parts of the brain are developing at different times in gestation, but the brain is vulnerable throughout. There are other factors such as maternal factors, other drugs, crystal meth, cocaine, marijuana, T's and R's. What can they do? In our lab animal experiments, individual administration of those compounds does not show the brain damage that we see through administration of alcohol. But there might be some compounding effect. There's also maternal genetic factors. Some of the differences in alcohol metabolism is one. We know that maternal nutrition affects the impact of alcohol. Many women will use calories from alcohol and not have nutritional calories. We know that mothers over time, the as the mother gets older and has more children, her children are more severely affected. And when we take nutrition histories, it's often her nutrition. She hasn't changed her alcohol use. It's the nutrition that's gone down. That doesn't mean that we just have to ensure that everybody eats while they drink to have a healthy pregnancy. But it's just these compounding variables. We know that the fetus brings their genetics too. Some fetuses seem to be extremely resilient, even when we hear and get direct alcohol histories, and the amount of fetal damage is far less than we'd expect. So what does the fetus bring in? We don't know. Twins are not equally affected, although theoretically they're getting the same amount of alcohol through the pipeline, through the placenta. The animal research has told us a lot about how alcohol actually causes the damage. It affects how the brain cells mature, how they migrate over the 9 months of pregnancy. The complexity of the neuron connections increases. The neurons go to different layers in the brain, establish their little connections, synapses with other cells. All that can be upset by the alcohol exposure so that the cells don't get to the right place, don't organize themselves, and don't function. Some other researchers at Queen's University have shown that the mitochondria, which is the little furnace of the cell, is directly damaged by the alcohol. And that it's not surprising from what we see in our children. The brain cells in the frontal lobe are more vulnerable to this mitochondrial damage. And when we talk about the function of kids, it's the frontal lobe functions that seem to be the most impaired in our children. Some of the work of Joanne Weinberg from UBC, she's working on the neurotransmitters, which are the important chemicals in our brain that are involved in learning and really in all of brain functioning, that they can be altered. And for somebody who's going to prescribe a medication to a child, the medications are based on neurotransmitters that are functioning. So no wonder medications don't work as predicted in the FASD population as well as in other populations. She's also working on the stress hormone cortisol and how this plays a compounding role in how alcohol damages brain cells. And she's working at we're talking the rat model still. But when we see our birth moms who are in stressful situations during pregnancy, domestic violence, fearful for their life, not knowing what's going to happen, a roof over the head one day to the next, their cortisol levels of stress hormone are high. So that's compounding how the alcohol is affecting both her and her fetus. We know that alcohol acts indirectly on how the nutrients get across from the mother to the child, to the fetus via the placenta. It can shut down the circulation. So our infant, a fetus may be getting alcohol, but not the same nutrient factors. We know that chronic alcohol use affects the mother's own health and ongoing effect on her lifestyle. Everybody asks me, what about the birth father? Because this is not just a woman's issue. Again, in the lab, the sperm appears not to be dramatically altered by alcohol consumption, chronic alcoholism. There may be other minor deletions on the dad's genetic contribution by the chronic alcohol or other drug use. But it is FASD means there's alcohol has been directly presented to the developing brain cell and its direct damage. So no, the father drinking does not cause FASD. It may cause other issues. And I think more importantly, it causes, if a father is drinking, there might be stress within the household that may act through this whole cortisol stress level. And when we're trying to help a birth mother do harm reduction and stop drinking or using substance during pregnancy, if she doesn't have a partner who's willing to support her through this process, it's extremely hard for her to, on her own, make individual change. we've got some new data from the human studies. I always say, it's easy to do experiments in rats. They behave. They take in fact, some of the work on the placenta is done here at the University of Alberta, and they use rats, and the rats, they like chocolate boost with alcohol. That's how they take it. So you can actually control all variables. We don't do that in human. The human experiment is so complex. But what are human studies showing us? We have found that there are MRI abnormalities in the brain, in the cerebellum, corpus callosum, and those are two really key areas of the brain for function. But most clinical MRIs are usually normal. Functional MRIs are, again, it's a research tool where you see what part of the brain is working as you have the child doing certain tasks. And Dr. Chudley in Manitoba has shown that, again, frontal area, less action in the prefrontal cortex as the child's expected to do increasing complex tasks. That's the opposite of normal. If we are challenged with more complex tasks, we get that area of the brain working harder. Our kids can't call on that reserve for some reason. Our own study here at the University of Alberta, we're using a distortion tensor imaging process, DTI. It looks at the connecting pathways between one area of the brain and the other. That's how the brain talks to each other. So you get information that comes in, goes to another area, it's processed, and then it gets put into a motor output, which is, the action. So there's a lot of this up and down, back and forth on the highways in the brain. And we've shown that there are significant reductions in some critical pathways and highways. So no wonder our kids seem to maybe get the information in, but then they don't ever find it again or use it, because if the highway is not functioning. And Dr. Susan Astley's recently published a paper on, there's your frontal lobe, decreased frontal lobe volume. And she correlated with her, because she's the lady who does the fancy digital imaging and software analysis of the face. So the frontal lobe is looking like it is the area of most vulnerability to damage. But it doesn't always stop with the alcohol in most of my kids that I see. We talk about interrelated complexities. Many of my children are not fortunate to end up in a very safe, stable home environment once they're born. And we know from the studies of Dr. Bruce Perry and his colleagues that early deprivation actually has a profound effect, not just on function, but we can actually see structural changes in MRI studies and functional MRI studies. And it includes not just severe abuse. This can be just lack of appropriate stimulation and malnutrition. And you think if you already have a brain damaged by the alcohol exposure in utero, you add this postnatal hit, you're going to have increasing complexity of dysfunction. And we also know that we talk about this vulnerable period for ongoing brain damage. This is also a critical period where it can do something. So in the early years, especially under age 5, that we want to optimize the opportunities to hopefully do some neuronal rescue. Can we rescue some brain cells, or can we do some, help that child at least establish the pathways that can be established to their most efficiency? So talking about who is at risk, who should we be concerned about? All cultures, all socioeconomic groups. And when we're trying to train family physicians and obstetricians about this disability, the most important thing is asking the question about the drinking history. And it should be incorporated into basic, I think, good health care of everyone, not just women, to be able to ask the question about drinking. There's still a lot of people don't want to go there, because what happens if she says yes? Then what do I do? How do I bring in supports? But it's really critical to ask the question in a non-judgmental way, and then to be prepared to develop supports if she does say yes. And it's not just asking about the drinking, but the why women drink. Reflecting on poverty, lack of education, the circumstances in her life. When Dr. Sterling Claren looked at his population in Seattle, Washington, about who are his birth mothers, high percentage of severe mental health problems, high percentage of had been homeless, had been children raised in the child welfare system themselves. So we're seeing patterns of not just drinking, but compounding situations. And that's why we need to, when we do prevention, and we won't have time to talk about prevention today, but there is one of the other talks available through this learning series on primary, secondary prevention, working with women. And we know we need to do it because I don't want to keep seeing my grannies coming in with the third and fourth generation. We need to break the cycle. And as I said before, safe amount is 0. So how do we do it? I've touched a little bit about asking the alcohol history, because that's the entry point into considering this diagnosis is alcohol. We can find it sometimes in our clinic by indirect methods such as birth records. Sometimes it's just checked off no. You wonder if they did really ask the question. We have to also make sure that the person revealing the alcohol doesn't have secondary gain, that they're blaming and shaming the birth mother. The direct interview of the birth mother, of course, is the most accurate, but how you do ask the question and being supportive to her, because it takes a lot of courage to come forward and say, I drank during the pregnancy. And with the moms that we do work with in our clinic, she will usually say, I'm doing it because I couldn't help my child then, and I want to see if I can at least help my child now get the resources that they need. And we always say in our clinic, when we work with birth moms, it's a diagnosis for 2. We still have a responsibility to help her. Where is she in her changes in her life? And we're very fortunate here in Edmonton and to have a program called First Steps, a mentorship program that works with moms who are at high risk of having children with FASD for a period of 3 years to help them address the why issues. And through the Alberta Cross Ministries endeavors, that program is going to be replicated under different names, probably called the PCAP model, throughout the province, so it will have, everyone will have equal access. We also need to have more specific programs for women entering into rehabilitation, because one of the things we do, we take their children away and we send them for rehab. Why does it have to be that way? Can we not have a child and mother focused approach? So that's something that needs to be developed and expanded on. Some of the biological markers for alcohol exposure, there is some research on taking the meconium, which is the first bowel movement that an infant has at the point, newborn has at the time of birth, analyzing it for a substance called fatty acid ethyl esters. And population studies and lab animals, again, have shown that there is a correlation between the substance, the FEE, and alcohol exposure. However, we know that meconium, which is the first poop, the bowel is not developed until the 13th week of pregnancy. So you can drink and drink and drink for 13 weeks and don't drink. Then when the bowel opens, you don't get any alcohol, any of this substance in the meconium. So you may then have, oh, this is great. There's been no alcohol. Baby's going to be safe. No risk. Or have an alcohol consumption later on in pregnancy. And I'm not saying one binge may not cause brain damage, but that would show up as a positive test. And as I said before, alcohol exposure is a risk. It's not a definitive diagnosis. So we really need to be careful with this as a potential biological marker to be able to follow up on any of the children who have a positive test, because I think we have an ethical and moral responsibility to monitor their development and provide supports for them and their caregivers. So that is still not a tool. In our own research, we've looked at a possible biological marker in eye movements of the child who's been prenatally exposed to alcohol. But again, we're just at the beginning of looking at this. Does it have potential? As we follow our group of kids for the next 10 to 15 years, we'll let you know. So right now, I don't have a nice quick MRI in my back pocket. I don't have a quick poop test or an eye test. But I'm very fortunate to have is I have a team, a multidisciplinary team. So I'm going to walk you through the diagnostic process. And just to get a sense, I'm not training you to become a diagnostician, but to give you a sense of, again, the complexity of the diagnoses and the rigor of what we need to go through to do the diagnoses, and why we need to have increased capacity for multidisciplinary teams so that there is equal access to a standard of diagnoses no matter where the child, teen, or adult may be. And I keep using adult as well as child and youth. We know we need to be able to open services for diagnosis for adults who may be affected by prenatal exposure to alcohol. So the diagnostic system starts with, who do you refer? Who should come to a clinic for assessment? Well, the most important thing is we need to access confirmed alcohol exposure. Just this week, I was asked to see a child who is adopted from the Ukraine. And I can't access that piece of history. So my focus is going to be on that child's functional needs. And hopefully I can write the report so that that is where the whole focus will be, not on just a medical term, because it should be driven by function. There's no screening tools. The Public Health Agency of Canada has brought a group together to look at screening instruments. Nothing jumped out as this is what we need to be doing. So more work there. But what we use in our clinic is confirmed alcohol and evidence that the child, youth, or adult is struggling, that they are not as successful in their life trajectory as expected. We work closely with the community because that's where most of our people are going to be identified from. And developing community partnerships and community understanding of this disability is so important. Because we find within our own community that often our partnerships with the school system, the teachers will wonder, could this child's difficulties be related to prenatal exposure to alcohol? People in the justice system, that client I'm working with, they just don't seem to get it. The strategies I use, and everybody else is successful, but we just don't seem to be, reaching that individual. Judges from the stand, they can often ask that same question. So I think, general awareness of FASD is really important from the community at large. They aren't diagnosticians, but they're raising the question. And I think in as we're setting up increased capacity, we have to make sure each community is ready for this type of approach. And also the community support during the diagnostic process. We have a lot of children who come to our clinic at the Glenrose from many rural areas. If the family comes with a support person who is able to help them understand the clinic process, be with the family during the outcome of the clinic process, and then translate it into action back in their home community, it makes a huge difference. Or else the diagnosis can just be a negative label. So our philosophy has been to develop tight community partnerships. The actual criteria for diagnosis, there's the physical criteria that I alluded to. We look for evidence of growth retardation, pre- and postnatal growth retardation. The third trimester of the pregnancy is a critical time. At some time in the third trimester, there's some biological changes, and if women do access improved nutrition, there can be a growth catch-up. There is 101 causes of small stature. and babies being small at birth. So we need to make sure that if the infant is presenting as being small at birth, or if we have a small child, that's not one of those causes. Malabsorption syndrome, just not being able to absorb nutrition from your diet, is a very frequent cause of small stature. So we use the cutoff of growth below the 10th percentile in height and weight as significant. We also it's good to know how big and small the parents are, because if you come from small stock, you're going to be small. The facial features, I mentioned before, the significant facial features happen day 19 to 21 of pregnancy. It's the same time, again, the front of the brain is developing. So, again, a very important time in development. Right now, we're redefining how we measure the face, population norms, because when we do measure the face, it's not in rocket science. There's the face that we see on the slide and in your handouts. The critical features, it's almost an underdevelopment of the midline of the face. So the nose appears to be shorter, the nasal bridge is flatter, but the critical features, the philtrum, which is the lines between the nose and the upper lip, the grooves, the philtrum grooves, are very flat, almost gone. The circularity, the Cupid's bow of the lip is thinner, and you don't have that nice Cupid's bow. What we also look for is the measurement of the eyes. We measure the length of the eye from the inner canthus to the outer canthus, so it's from the nose to the outside of the eye. And that's much smaller in children prenatally exposed to alcohol early in pregnancy. So it's not rocket science. Dr. Astley does a photograph. What we do in the clinic, we do the photograph as well. But I have a little lip philtrum guide, so I have a little samples of what normal lips look like and the full face of FAS, and I just simply match the child to the picture. And I've got different guides for different ethnic groups, such as Afro-American. The size of the eyes, Dr. Chudley in Winnipeg, Manitoba, and Dr. Claren in BC have just repeated. They've done thousands of children, so we have new Canadian norms, so that we'll be measuring against new norms. But as you can see, it's not rocket science to do the measurements. But what I also have to do is make sure it's not another genetic syndrome that's a look-alike. So there are other faces that have a similar look. But what I see at the end of the day, in our clinic, less than 10% of the children have any dysmorphic facial features. It's not the face, it's the function. And that's where we spend most of our clinic day, looking at how the children's functioning is impacted by the alcohol exposure. So we're looking for patterns of disordered learning, problems of behavior regulation. It's really a spectrum of minimal brain damage. And it does take a team. Some of the things that we see, developmental delay or disorder, disorganization, impulsivity and attention hyperactivity, that ADHD pattern. We sometimes see IQ deficits, but not always. IQ, we do require that to be measured because what we see at all the other functions are far lower than you'd expect for the IQ level. And this is an example of the normal bell-shaped curve of IQ, and this is an old study by Dr. Strysgrith. The gray bars are the FAE subjects. The black bars are full FAS subjects. And as you can see, anything over 80 is considered within the average range. So many full FASs are going to have, you may have an IQ of 120. So you can't use IQ. But the function concept is how you function is often much lower than your IQ. Variety of learning disabilities, especially for math, functional communication deficits, and impaired ability to function. It's really how you can't get through a day without supports that really defines this disability. And we see difficulties in judgment, memory, difficulty generalizing information you learn in one situation, can't apply it to another situation, organizing, planning, sequencing, not able to learn from life experiences not able to connect cause and effect. Those are the things that come out during our assessment. And these are all a result of that brain damage, primary disability from the brain damage. So if all you remember from what is FASD? It's a disordered pattern, out of keeping with IQ, increasing difficulty with age group. But the paradox, at a young age, it may not be evident if that skill is not expected. It's often in a supportive environment, our kids can look very good. My caregivers do phenomenal jobs. Take the support away, and you see the hard work that has gone in to keep these kids doing the best they can. And it's often invisible disability, so other people have that expectation that they should be doing better. It's that they simply won't, and forget it's that they can't. So I always say my kids pass tests and flunk life, in a nutshell. And I'm just going to quickly go through some of the other things that we need to remember. Alcohol-related birth defects, that alcohol damages other organ systems. And this is important for healthcare providers. So many of my kids have vision problems that have never been identified, heart defects, hearing loss, tethered cords. So the importance of whoever the healthcare provider is doing a thorough physical exam to make sure we're not dealing with something else that's going to compound their health. During our clinic assessment, we consider all the other factors that I've alluded to. We have the alcohol exposure. Okay, what other drugs could have been in part of their exposure? Do we have access to the genetic factors? We know that some significant mental health issues, depression, schizophrenia, there is a genetic factor, some multi-genetic factors. We try to access that. We also try to get a picture of the postnatal life of the child. How many placements? Have they been a victim of abuse, neglect? Because we know that can lead to secondary disabilities. So part of the clinic process is, what else could it be? So that's where a physician's an important person on the team to know about all the genetic syndromes, all the other conditions of short stature. Is this just simply ADHD and not an ADHD pattern as a result of prenatal exposure to alcohol? Is there another acquired brain injury? Was that child born extremely prematurely asphyxiated at birth? Could that explain everything? Did the child have brain injury from an abuse? And the differential diagnosis of mental handicap and learning disabilities and other psychiatric disorders. So it just adds to the complexity of the assessment process. What else could it be? And there's this long list of other diagnoses that often end up on the list for that individual child. For some reason, there seems to be a higher incidence of Tourette's syndrome in children prenatally exposed to alcohol. We don't know why, but it may be that the area of the brain involved in Tourette's is more vulnerable to the alcohol damage. There's quite a bit of anxiety and depression in our population. Is it because of their life experiences or because of brain damage? And there's some new evidence that some of the psychiatric disorders may be rooted in brain damage and not just due to environment. And that's is being sorted out. We know that many young children receive a diagnosis of reactive attachment disorder in addition to their FASD diagnosis because of them not having the right environment for them to form significant attachments early on in life. Post-traumatic stress disorder needs to be identified and addressed as well in this population because it does require a very special treatment support through play therapy with a counselor who's very familiar with this population. I mentioned secondary disabilities, and the theory behind secondary disabilities is that they aren't caused by the brain damage. They're caused by repeated failures of not being understood, of being set up to do better than you can, and also the multiple environments. Often we find, especially if there has been a delayed diagnosis, that there's a lot of frustrations for both the child and caregiver. So theoretically, this is all preventable. Dr. Anne Streisgrith has done a lot of work on this, and She's looked at all of the mental health disabilities that go along with secondary disabilities, and they're all of a mental health nature. They've also, a lot of the group that she studied, they were also either victims of abuse themselves, taken advantage of, being set up to get into trouble with the law, not intentional. They're not capable of independent living, but appear more capable. So in her study, she actually has followed people for now over 35 years since the Seattle, Washington Clinic has been diagnosing. And she said that the people who did best were the ones who received a diagnosis before the age of 6 years, had stable home environments, access to early intervention, and weren't victims of abuse. When we're working with adults and adolescents, often those secondary disabilities and the mental health is what brings them to attention. And we've got some good partnerships with our colleagues in psychiatry and mental health, and they're actually referring a lot of children that they're working with to our clinic because they do access the alcohol history. That wasn't the reason the kids came to their mental health caseload, but it's all the other mental health issues. So what we need to do, the mental health issues are definitely there, but we need to shift back. Okay, what is the underlying organic brain damage that is part of that person? Because if you'd use the standard mental health treatments for the anxiety, depression, and so on, in somebody who's got brain damage, especially a cognitive approach, you're not going to be successful. But if you shift your thinking, I'm dealing with somebody with brain damage, and put in an approach that you'd use for brain damage with looking at how can we change the environment, you're much more likely to be successful. So that's that whole reframing of your opinion of that individual and reframing your strategies. And as I've mentioned, there's some new evidence that some of the secondary disabilities may be rooted in organic brain damage, but we need to really find out more about that. What happens on clinic day for a diagnosis? We use a tool that was developed in Seattle, Washington by Drs. Astley and Claren, and it's called the DPN tool. DPN stands for Diagnosis Prevention Network, because it strongly links that we have a lot of prevention to do of secondary disabilities, and prevention by reaching back to the birth mother to prevent further children being born affected by alcohol. There's been a lot of recent research within the Canada Northwest Research Network to actually really redefine how we approach the diagnoses. It is becoming much more objective and quantifiable. So it's not just, he acts like he has FASD. We can actually measure some of the areas of deficit. But we also pick up on strengths, because that's where you hang your hat for interventions, on the strengths. So what the 4-digit code does, it looks at those factors: growth deficiency, facial features, the brain dysfunction, alcohol exposures, other pre- and postnatal factors. And we're not training you for FASD diagnosis, but we then put a numerical ranking on them, weight them as no risk, some risk, low risk, high risk for all of those factors. We do the same thing for the prenatal factors. We rank all the postnatal factors as well. We rank the alcohol consumption. So we're getting quantifiable numbers in each of the areas. The physical part is easy. Measuring growth, height and weight, looking at the face and measuring the face. And as I said, the physician does the health monitoring as well. We spend a lot of time interviewing the caregiver to get a sense of how that child has changed over time, past history and current challenges, and how committed they are to the child. We spend a lot of time with the child, youth or adult, and interviewing them and observe them during our whole clinic day. The assessment, we don't have a single test, so that's why sometimes it's clinic days that the assessment takes place, because we do need to give frequent breaks and allow that person to recharge. So It's a multidisciplinary team of speech language pathologists, occupational therapists, neuropsychologist or psychologist, social worker, physician, and team coordinator. And all team members contribute to the assessment. We're trying to get a picture of what this brain looks like. And it's integrating, it's not one single test, but we integrate all the information. And we look for 3 areas of impairment that are below -2 standard deviations on standardized tests. And we still have a lot of research ongoing in that area. These are the domains that we look at: intellectual, academic, attention, sensory, motor, neurological, visual, spatial, aspects of communication from basic communication skills to that higher level. Do you actually use your words to convey meaning and understanding? Do you use your communication for effective social functioning? And a really important area is perspective taking. Do you understand that another person has a different point of view and sees the world differently, so that you have to be clear in sharing your ideas? This lack of perspective taking is one of the fundamental things that gets a lot of our kids into a lot of trouble. The fact they do something and you're angry and mad, and they don't see that you're angry and mad because they're happy. It's not that they're cold and callous. They lack perspective taking. We look at all aspects of memory, including getting it in, finding it again, and working with the information. Executive functioning, this is the area that my clinic researcher, Dr. Carmen Rasmussen, is doing a lot of work. Executive function means judgment. Can you inhibit? Do you have the mental flexibility to handle 2 or 3 things at once? What about your problem solving? Can you plan and sequence and organize all this information? Can you initiate your task? Stick with it. Can you shift when you need to shift? And what is that whole abstract reasoning process? Adaptive functioning is another key area. Can you take all of this information and then simply get through a day without additional supports, independently on your own, without being victimized? And can you go on to carve out your own life? We also spend time on the mental health. So I'm going to give you a snapshot of what this looks across the lifespan and what strategies we try to put in place. Newborn and infancy is, of course, a very important time. If you remember, Dr. Streisger said, the earlier we get a diagnosis, the better these kids seem to do. If we have alcohol confirmed in the newborn period, it's only a risk factor. I cannot make a diagnosis in a newborn. What I need to, if I have the alcohol history, though, I need to be very aware. Can this child present with neonatal abstinence syndrome, which is, it's not really withdrawal. I think this is the first symptom of brain damage. The newborn's brain adapts beautifully from birth. It begins to self-regulate to the outside world. It begins to know what is the appropriate stimulation level that they can accept and what they can complain about. In children prenatally exposed to alcohol, this ability to do smooth adaptation can often be quite disordered. And these children, it can affect the way they simply behave. Tremors, poor coordination of suck, swallow, very irritable. The least little thing will set them off. Very difficult children to both nurture and nourish. And there is a treatment protocol that we sometimes need to put in place medically and also with supports. We also need to look, are there any of those alcohol-related birth defects, especially cardiac? We also need to look at the caregiving situation. If mom has admitted to using alcohol, where is she in her journey of healing, of change? What are her support systems? It's really an optimal time to reach mom without that blaming, shaming, but how can we help both you and your child stay together and thrive together? So birth moms need a lot of supports, and to mention, we are fortunate to have First Steps program here in Edmonton, and there is going to be accessibility of this PCAP model throughout the province to work with these birth moms. If child cannot go home to birth mom, is going to go to a different care provider. Training and supports mean it will need to be put in place. And I've had so many foster moms say, I was never told that child was prenatally exposed to alcohol. And you know, I ended up saying I can't foster this child any longer because of the degree of, you know, the work. And had she known about the alcohol, we could have put in some education training strategies to help. And I know this is is being incorporated into a lot of foster care training about what to look for and how to access resources. And in this very young age group, we try not to use medications. Sometimes we're forced to in a neonatal intensive care unit in order to have the baby at least begin even to take nutrition. The best supports are supports around reducing overstimulation, the whole sensory environment, and different feeding techniques. But it's not diagnostic of FASD, but boy, this little babe does need follow-up and needs to have access to the most supportive, nurturing environment we can possibly connect him with. Toddlerhood brings its own challenges. Sometimes we do see delays in those basic milestones of walking, talking. Often they're not delayed, but it's the quality of movement. They're busy, they're disorganized, they bump into everything. They have a lot of trouble regulating their responses. Active and busy is usually what the description we get. Overly tactile, you need to kind of touch everything without really playing with it. What we can assess in the preschool age group, we can look at their basic language skills and fine motor skills, and we use community therapists for that assessment. They're usually mildly delayed. There's some issues. Again, not specific for an FASD diagnosis. So there's the paradox. Dr. Streisgruth, everybody's saying early diagnosis leads to better supports. But to be fair to our kids, we haven't got evidence of organic brain damage. We've got pink flags, and the intervention should be based on function. Seeing some of our kids in a good environment, they actually can really present as doing very well. Again, because they're in the right environmental supports. But because they look good, if we've got the risk of alcohol, the alcohol exposure as a risk factor, they need to be, again, ongoing monitoring. Because some of their difficulties are mild and moderate, they often may not qualify for our services. We spend a lot of time, again, talking to the caregivers how to optimize an environment, provide structured play opportunities, stimulate language development, and lots of supervision for safety. Many of our children are in foster care system, and helping with forming a healthy attachment to a significant caregiver is a huge issue and needs to be emphasized in treatment programs. So at this age group, interventions based on individual needs, a lot of sensory supports seem to be helping these kids. This is not sensory integration disorder. This is common sense sensory things about not overstimulating, giving the children one thing to play with at a time, helping them learn to regulate some of their own behaviors. They need a lot of help in social functioning with supervised play dates. If the child's in a program, a strong communication between program and home. Caregivers can burn out when we're putting this level. You have to look at how your environment is working, level of supports. Caregivers need to take breaks. We have some good examples of respite programs for the kids. Coaching Families through Catholic Social Services does provide a great deal of kind of coaching and strategy and supports for people who are raising children with FASD. Certainly not enough supports. Ongoing need for treating attachment, and time doesn't permit, but we do have a foster pilot project around helping foster parents with this. The next age group, your kindergarten age group, big transition time. Going from what might have been either a more structured setting in an early intervention program into a larger group where there's more demands both to learn, to function socially on your own, and our kids have difficulty. They have troubles getting the social cues, they're overly tactile, they're in your face, and don't get the message when another child backs off. They often are very talkative, very chatty, and understand less well. But we often get the comment, but they sound so smart. But why don't they do what I'm telling them to? Well, they're not understanding. They can often echo back what you said. Go do X, Y, and Z. What did I tell you? X, Y, and Z. Then why didn't you do it? Well, I told you X, Y, and Z. Being able to understand and then put it into action. they often appear to have behavioral regulation difficulties of ADHD. We get a lot of tantruming presenting at this age group, and often the tantruming is the fact that they're probably overwhelmed. The tantruming is a communication. I don't know what's expected of me. I'm overwhelmed in this situation, and I just want out. So the only way I know out is down on the floor. So trying to anticipate situations to prevent that from happening. That group learning situation is a real demand. They don't get as much one-on-one help as in the early education, early intervention time. And we know with our school system, the amount of one-on-one help becomes quite diluted as you go through the different grades. And that's where the gaps in early learning can begin to show. Often when we do assessments of basic language, fine motor skills, and their early learning pattern, we will see some delays in areas, but again, it's not diagnostic of brain damage. We are beginning to see, especially in just around age 6, we've recently had some children where with some of our newer testing, we can actually pick out the brain damage. But for most kids, we will often defer their diagnoses, but drive the supports based on their functional needs. We spend a lot of time in clinic with this particular age group, helping the caregiver get a handle on how they can support their child in day-to-day living and also look after themselves. The next age group in transition time is grade 3 to grade 4, ages 8 to 10. And that's where we have expectations that you're going to be even more dependent and self-organized. You're going to handle more abstract concepts. And that's where the executive functioning, social communication deficits and self-regulation are so evident, both by caregiver interview and by just being with the child. We can often see them slipping behind academically, especially as the language demands of learning increase. ADHD patterns very common. Social difficulties continue. Difficulties with organizing without help in home and school. And they often do worse in recess than in the actual classroom setting because of lack of structure. The same communication pattern, talkative, tangential, but lacking content and connections, not learning from consequences, impulsive, poor judgment, can't generalize. We see lying and stealing emerging, and it's not intentional. It's often that lack of perspective taking because they don't see the impact of that lying behavior on others. Can also present with a lot of mood swings, behavior regulation, problems in motor planning. So you can see the complexity emerging over time. At this age group, we can actually do a lot of assessment one-on-one with the child, and we can assess all domains. We can do direct memory testing, executive functioning testing, and formulate a diagnosis. And so at 8, people say, what's the best time to have kids come to our clinic? Between ages 8 to 10. Recommendations and strategies need to be multiple, educational, and more importantly, when they're not in school. Don't expect independence in social settings without supports, good supports. ADHD may need to be addressed. Learning disabilities certainly need to be addressed, and the support for caregivers with a coaching families type of model is extremely important. Get to adolescence, and I often say adolescence is just a stretched toddler. The strategies that you used when they were 2, you continue when they're 12, when they're 22. It's just a bigger package. You see, it's very evident with the behavioral and emotional regulation difficulties. We see the emergence of some of the secondary disabilities. And educationally, that's the time where the academic load needs to be decreased and shift into practical life skills. And this often, especially the late teen to adulthood, we see more of the secondary disabilities as being the presenting symptom, the mental health issues. And we need to kind of go back and get to the alcohol history in order for us to put in the appropriate strategies. And it may sound as if there is no opportunity for success. As we've seen the shift from supportive environment, letting that individual reach their potential, with continued supports. There are success stories. There are lots of people affected by prenatal exposure to alcohol who will be able to, with supports, don't take them away, but with supports, be contributing members of society and not requiring the $1.2 million of supports. We want to prevent loss of self-esteem. We want to help them not become users of substances of abuse themselves. Because what happens if you feel you're not being successful academically, socially? The most common thing for self-medication is reaching for alcohol, especially in our teen population. So in this teen and young adulthood, a lot of attention to substance abuse risk. So key points across the lifespan, how it presents looks different at different ages, can be impacted by a positive negative environment, usually an invisible disability, increasing gaps in function over time, and how to prepare caregivers for this journey. And that's I think, caregivers as well as teens. We do, when teens come to our clinic for diagnosis, we spend a lot of time with them after diagnosis. What does this mean for you? What does this mean that you might not be able to do, but it's okay to ask for help? And coaching teens at a young age to be able to ask for help when they need it is huge. And there is a new teen program that has been developed through Catholic Social Services to actually continue to provide that support for teens. And in the essence of time, I'm just going to slip into some what next. Why assess FASD? It's not a label for funding for schools. It's to help that individual be understood as having brain damage and therefore needing this type of support across their lifetime. We need more evidence about what that support should look like. We have an idea about some intervention, what interventions and supports look like for young children. We're just beginning to get some more understanding of what the teen needs, what the young adult needs to be set up for success in terms of independence and employability. We need more evidence and research. So that was one of the outcomes of our consensus conference on FASD. Let's get the evidence. We need to do more on prevention and working with our birth moms and preventing FASD, secondary disabilities and FASD. Again, the consensus conference call for more research. So here's some of the questions that we are asking ourselves. Are we making a difference by diagnosis and what we currently know about intervention? And what is the impact on the quality of life? We're talking a lot here about function, but what about quality of life of the individual with FASD? We haven't asked them. We need to ask them more about that. What is the impact of FASD on their caregivers across the lifespan? Again, what is the evidence that specific support programs work? And how can we ensure that there is a seamless flow of supports at key transition points across the lifespan? Because that's actually the model of brain injury. We put in supports, we modify them according to the age needs of the individual. We never take them away. So I think from our learnings in brain injury, we can apply them to this population. We know we need to have more access to multidisciplinary teams for the consistent diagnosis, that whole sustainable funding, and as I said, that research can drive the best practices, and we can then go to the policy people and say, this is how we know we can do a better difference. Talked a bit about the need for more information on prevention. The best success has been to target all aspects of prevention from public awareness, that everybody gets the messaging. We then target more risk populations and giving them the supports that they need. And I mentioned briefly before that there is a lot of evidence that the programs that work with the women at highest risks in this mentoring model can be successful, can break the cycle. So this has been a very fast overview of FASD 101, from the biology of alcohol, brain cell damage, to what does this look like across the lifespan, the complexity of the diagnoses, and some of the supports that need to be put in place. And so I've been working with this population for many years, and I wish I knew now what I knew 20 years ago, because I've learned to do things differently. And I think Diane Malbane is one of the people who's done a lot of work on strategy and interventions. And that's one of the things she says. It's not trying harder, it's trying differently. And I think we do have the opportunity to do what Dr. Strathgrove has done in Seattle. She's followed her group up in over 30 years. We need the opportunity to continue to work with, as we diagnose a child with FASD, to follow them across their lifespan and learn with them and their caregivers what's working, make sure that's put in place, and then ultimately, so that when they then go on to be the parents of the next generation, they break the cycle. So I won't have my grandmas, and actually the family that visited me today, she was a great grandma. So we missed there, but I think we have opportunities that we can't miss. So thanks for your attention on this Friday afternoon. And I think the mechanism for questions, I'll certainly stay here for questions, but from other people who are going to be accessing this information, and there'll be opportunities for electronic questioning to be sent on, and I'll try to answer them as best as I can. And I do have a team, so if I haven't got the answer, I'll call on one of my colleagues.